The webinar will begin soon. Please stand by. The webinar will begin soon. Please stand by. Good afternoon, everyone. I'm Laura Morell, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on March 2nd, 2022. Next slide. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/onehealth/zohu/2022/march.html. Next slide. Today's presentations will address one or more of the following 5 objectives. Describe 2 key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topics. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. And identify 2 new resources from CDC partners. Next slide. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, presenters, and their spouses or partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there is no bias. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this activity. Next slide. Instructions for receiving free continuing education are available at cdc.gov/onehealth/zohu/continuing education. The course access code is ZOHU Webcast. To receive free CE for today's webcast, complete the evaluation at cdc.gov/tceonline by April 11th, 2022. A captioned video of today's webinar will be posted at cdc.gov/onehealth/2022/march.html within 30 days. To receive free CE for the web on demand video of today's webinar, complete the evaluation at cdc.gov/tceonline by April 12th, 2024. Next slide. Before we begin today's presentations, Dr. Casey Barton-Baravesh, Director of the One Health Office, will share some news and updates. You may begin when you're ready.
Thank you, Laura, and greetings, everybody. Welcome to the March ZOHU Call webinar. We really appreciate you joining us today. Before our presentations begin, I want to share a few updates. And as always, you can find links to these resources in today's ZOHU Call email newsletter. If you're not yet subscribed, all you have to do is use the link at the top of the main ZOHU Call webpage to access these resources. Our response to the COVID-19 pandemic continues to evolve. Please check CDC's website for the latest guidance and resources, including information about keeping people as well as animals safe and healthy. Our next One Health Partners COVID-19 webinar is scheduled for Tuesday, March 29th at 2 o'clock Eastern Time, If you'd like to join this webinar to hear more about the One Health aspects of COVID-19, just email us at onehealth@cdc.gov and we'll add you to the distribution list. Next slide. While there's no evidence that animals are playing a significant role in spreading COVID-19 to people, we do continue to see a variety of different animals reported with the virus that causes COVID-19. In the United States, 356 animals have been reported, including companion animals like cats, dogs, and ferrets, animals in zoo sanctuaries or aquaria, including hyenas, large cats, a binturong, a fishing cat, coatimundi, otters, and gorillas. There are production animals like mink and also wildlife like white-tailed deer. 17 mink farms have been affected by SARS-CoV-2 in the United States to date, and you can find the latest animal case numbers available on the USDA APHIS website. And of course, we have guidance for pet owners, mink farmers, veterinarians, and many others on CDC's website. Next slide. You'll find links in today's newsletter to several recent publications, including risk factors for hospitalization among adults aged over 65 years with non-typhoidal salmonella infection linked to backyard poultry contact, and also highly pathogenic avian influenza is an emerging disease threat to wild birds in North America. Next slide. We've shared links to several recent announcements, including that there's a new population survey data on FoodNet Fast, and that CDC reports a new US human infection with the variant influenza. Next slide. We've also shared links to new web resources, including our brand new Why is One Health Important infographic and the antibiotic resistance investment map. Next slide. Some upcoming events of interest include the National Invasive Species Awareness Week, currently being observed through Friday, March 4th. And we're actually going to hear a presentation related to this observance today about feral swine. And there's another event coming up April 4th through 7th in Atlanta, and that's the Preparedness Summit, Reimagining Preparedness in the Era of COVID-19. Next slide. And finally, there are ongoing outbreak investigations, including a salmonella outbreak linked to pet bearded dragons, an E. coli outbreak linked to packaged salads, and 2 listeria outbreaks also linked to packaged salads. Please visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past US outbreaks of zoonotic diseases. And we appreciate you sharing the ZOHU Call website link with your colleagues from human, animal, plant, and environmental health sectors and other relevant partners, and letting them know about the live webinars, video recordings, and free continuing education. Our next call is scheduled for April 6th, 2022. And please send presenter and topic suggestions for future ZOHU presentations, as well as news from your organization that you'd like for us to share with our newsletter to ZOHUCall, ZOHUCALL, @cdc.gov. Now I'll turn the call back over to Laura. Thank you.
Thank you. Next slide, please. You can submit questions at any time using Zoom's Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation if time permits. You may also email questions to today's presenters. We've included their email addresses on this slide, on the ZOHU Call webpage for today's webinar, and in today's email newsletter. Next slide. Our first presentation, 3 US human rabies deaths linked to bat exposures in August 2021, is by Amber Kunkel. Please begin when you're ready.
Thank you, Laura. So I'm an EIS officer in CDC's poxvirus and rabies branch, and I'll be talking today about 3 human rabies deaths in the US this past year that were all linked to bat exposures in August 2021. Next slide. Rabies is the deadliest zoonotic disease in the world with a nearly 100% fatality rate. Exposure to rabies primarily occurs through a bite when virus in the saliva is introduced into a break in the skin. Rabies virus is neurotropic, meaning it seeks out nerve cells for replication. The virus makes its way to the brain, typically over the course of 3 weeks to 3 months, but this time frame can vary. The end goal of the virus is entry into the brain, massive replication, and excretion in the salivary glands. Reservoir species typically shed virus for several days before they look sick and can survive and shed for about 1 more week. Humans generally die within a few weeks of symptom onset, and secretions are assumed to be infectious up to 2 weeks prior to symptoms. In humans, signs and symptoms vary, but typically begin with pain or paresthesia near the site of the bite, or nonspecific symptoms like fever, and they can progress to confusion, agitation, delirium, hydrophobia, and/or hallucinations, almost always leading to death. Next slide. Rabies causes more human deaths each year than any other zoonotic disease. It's estimated that about 59,000 people each year die from rabies. Most of these people live in Africa or Asia and acquired rabies from dog bites. Although post-exposure prophylaxis, or PEP, is very effective at preventing rabies, people may be unable to obtain PEP or not even know to seek it out. In the US, the canine rabies virus variant has been eliminated, but rabies persists in certain wild animals with occasional spillover to domestic animals or humans. About 60,000 people each year in the US receive PEP for a suspected rabies exposure, preventing many possible deaths. Next slide. Modern day post-exposure prophylaxis in healthy individuals involves 4 doses of rabies vaccine given intramuscularly over a period of 14 days. It also includes an initial dose of human rabies immune globulin as passive antibody coverage until the patient begins responding to the vaccine. Thorough wound cleansing is also important for reducing risk. Next slide. This map shows the distribution of rabies in terrestrial mammals in the US. Rabies is enzootic to raccoons, skunks, foxes, and mongoose in the US within specific geographic ranges. Other mammals can also acquire and transmit rabies if they're exposed to the saliva of a rabid animal, but these transmission chains generally die off within a generation or 2. Next slide. And then there's rabies in bats. Bat rabies is found all throughout the continental US and Alaska, with the highest detection of cases shown on this map and often corresponding with population centers. Next slide. In recent years, since elimination of the canine rabies virus variant from the US, human rabies deaths in the US are most often caused by exposures to bats, as you can see by the black bars in this figure. Since 1960, about 70% of human rabies cases acquired in the US have come from bats. Next slide. Most human rabies testing in the US occurs at CDC. We are typically contacted by a physician or a health department who believes a patient may have rabies, and we will agree to test when the state health department supports testing, the patient has a clinical course consistent with rabies, and the patient has either a concerning exposure history or other more common causes of encephalitis have already been ruled out. Both antemortem and postmortem testing is possible. After a positive test result, CDC supports the health departments and clinicians by providing guidance on the public health response, infection control, and communications. Next slide. The number of human rabies deaths detected each year in the US is low, generally between 0 and 3. In 2019 and 2020, there were no cases detected. In 2021, 5 human rabies deaths were detected in the US across 5 different states. 1 was attributed to a dog bite in the Philippines and 4 to bat bites. Of these, 3 showed particular similarities in that all followed exposures in August 2021 and none of the patients received PEP. Next slide. The first of these 3 deaths occurred in Illinois. In August, a man in his 80s contacted his local health department to report seeing a bat in his bedroom the night before. The man provided inconsistent reports on whether he had direct contact with the bat. The bat was submitted for rabies testing and confirmed positive. However, the patient refused to receive PEP despite urging from the local health department. This refusal was apparently linked to a general vaccine hesitancy related to an adverse vaccine reaction that the patient had experienced several decades earlier. Approximately 4 weeks later, the patient saw his primary care provider and reported a 1-week history of neck pain and arm paresthesia. He told his doctor about his exposure to a bat with a positive rabies result and was referred to the emergency department. The patient developed fever, hypersalivation, and altered mental status, and died a few days after hospital admission. This is the first case that we know of in the US where PEP was recommended and refused, and it was apparently due to vaccine hesitancy. Next slide. The second case was confirmed from Texas. This case involved a male school-age child who had touched a bat with his bare hands outside his home in August. He reported to his parents that he had been bitten, but the parents did not observe any visible bite marks, and they did not realize that bats could transmit rabies even if there is no visible bite. No medical advice was sought, and the child did not receive post-exposure prophylaxis. The patient had a 3-week course of illness before death, including agitation, delirium, hypersalivation, and seizures. Next slide. The final case occurred in Idaho. This case involved a man in his 60s who had a bat collide with him and become tangled in his clothing, both outside and inside his home, although he did not notice a bite. Because he did not realize the potential risk of his exposure, he did not seek medical advice or receive PEP. 6 weeks later, he began experiencing a 3-week course of illness, including arm and neck pain and ascending paralysis, leading to his eventual death. Again, this case highlighted that direct contact with a bat is a risk for rabies, even without a recognized bite or scratch. Also, rabies was not suspected for this patient until late in his course of illness, which shows how additional rabies cases in the US may occur but never be detected. Next slide. This slide shows a video that the Idaho patient took of the bat after it became tangled in his clothing. Based on this video, experts assessed that the bat species was big brown bat, but sequencing of the viral strain showed a rabies virus variant typically found in silver-haired bats. Next slide. A public health investigation was launched in each state to look for individuals who may have been exposed to either the infected bat or the human patient. The greatest number of community contacts were identified in Texas, where 41 people ultimately received PEP. The number of healthcare contacts per patient were generally low, possibly related to greater use of PPE during the COVID pandemic than in the pre-pandemic era. If we compare to 2 cases that occurred in 2017 and 2018, we can see a big drop in the number of healthcare contacts who required PEP pre-pandemic, about 70% compared to 1 to 10 in our 3 fall of 2021 cases. Next slide. Following these 3 cases, we felt it was important to share bat rabies prevention messaging with the public. CDC and the state health departments took several steps to do so. Next slide. First, each state released a press release about the deaths that had occurred in their jurisdiction. These were picked up by some media outlets as shown here. Case reports of each individual case, as well as the other 2 rabies deaths that occurred in the US in 2021, are also in progress. Next slide. We updated the CDC webpage on bats and rabies to make it easier to navigate and understand. This page includes information on bats and rabies, what to do if you encounter a bat, how to safely capture a bat for testing, and how to keep bats out of your home. Next slide. For example, here are the instructions on safely capturing a bat for testing. Capturing and testing bats can prevent people from receiving unnecessary PEP if the bat tests negative, but it's important to do so safely to avoid any additional bat contact. When trapping a bat, people should wear leather work gloves and place a container over the bat to capture it, avoiding touching the bat with their bare hands. Next slide. Next, recognizing that the occurrence of these 3 human rabies deaths in such a short amount of time is rarely seen in the US, we attempted to promote healthcare worker and public knowledge about the risks of bat rabies by publishing an MMWR Notes from the Field. This report described these 3 cases and how to prevent rabies transmission from bats to humans. Our key messages were that direct contact with bats can be dangerous, even if there is no visible bite or scratch, but the transmission of rabies from bats to humans can be prevented. To prevent rabies transmission from bats, people should first avoid contact with bats, for example, by excluding bats from homes. Don't touch bats with bare hands. Second, if contact does occur, do not release the bat and instead contact your local health department about having the bat tested for rabies. Finally, if the bat cannot be tested or test positive, post-exposure prophylaxis may be needed. Contact your doctor or local health department to ask if you should receive PEP. Next slide. Our communications team put out a press release simultaneously with the MMWR and was successful at getting significant media attention from nationwide news outlets, including the AP, Stat News, and the New York Times. We hope that getting these stories out there will remind people that rabies from bats remains an ever-present risk in the US, despite there being no cases in 2019 and 2020. Next slide. CDC also put out social media messaging coinciding with the MMWR to further spread the word. Next slide. In conclusion, 5 human rabies deaths occurred in 2021, an increase from recent years. 3 of these were linked to bat exposures that occurred in August of 2021. Of these, 1 refused PEP and 2 did not realize their contacts posed a risk of rabies, so they did not seek PEP out. These deaths suggest a need to educate the public on how to avoid getting rabies from bats, which CDC approached using an MMWR, news media, and social media. When it comes to rabies and bats, knowledge is key to getting people started on PEP and protected from rabies. So I'd encourage all of you listening to share these stories with the people around you as well. Next slide. I'd like to acknowledge everyone who worked on the investigation of these cases, as well as the write-up and communications efforts. Thank you all for listening. That's the end of my presentation.
Thank you. Next slide, please. Our next presentation, Serosurveillance for Anthrax Exposure in Texas Feral Swine, a potential biosurveillance tool for mapping risk, is by Rachel Mason and Angela Bosco-Louth. Please begin when you're ready.
Great, thanks everyone for joining us today. I'm Angela Bosco-Louth. I'm at Colorado State University, and presenting this information today is PhD candidate Rachel Mason, who's done a lot of work in feral swine, and particularly looking at serology for use for serodiagnostics for potential pathogens. So Rachel, go ahead and take it away.
Thanks, Angela. Next slide, please. So just to kind of jump right in, for those of you who aren't aware or don't know, feral pigs are an incredibly destructive invasive species in the United States. They were actually introduced to the US back in the 1500s by Spanish settlers who were colonizing the continent at the time, and just kind of released onto the landscape just to provide an easy source of food for the people who were colonizing the US at the time. But since then, their populations have exploded to encompass most of the southeastern United States, as well as some western states. And this is mostly because pigs as a species are very good at adapting to most environments. They are omnivores with a very generalist diet and have a very high reproductive rate, as well as can give rise to very large litter sizes. And today it's actually estimated that feral swine cause around $1.5 billion worth of damages annually, specifically to property and agricultural crops. This is because pigs like to root and wallow in the soil, and in this way can more or less act like unwanted rototillers on the landscape. They're also known to displace native wildlife, either directly through predation or indirectly through resource competition and sheer ecological destruction, again, through their rooting and wallowing behavior. And then lastly, and arguably most important for this talk, feral pigs also can have indirect and direct interactions with humans and domestic animals and livestock species, which in some cases can have implications for the transmission of pathogens and disease. Next slide. So I'm sure many of you are or have heard of anthrax disease, and so its introduction might not require too much of an introduction to you all, but there are a few things worth highlighting about it, and its causative agent, Bacillus anthracis, just to give you all some context to why we were interested in this pathogen specifically and how it might relate to feral pigs. So it is caused by the bacterium Bacillus anthracis, which is a soil dwelling bacterium. It is endospore forming and can actually lie dormant for decades in those soil profiles. There are reports in the literature that have isolated spores and have dated them to be over 100 years old. So it is a very long-living pathogen. But despite how long humans have seemingly been dealing with this disease based on historical reports, we still don't have a good handle on the true incidence of anthrax disease in most regions. And the bacteria has been isolated pretty much from every continent. So it's just kind of assumed that you might be able to isolate anthrax from most regions, but we don't have a good handle on its distribution on the landscape or its disease incidence. And then lastly, and most importantly for this talk, it seems that anthrax doesn't affect all species equally. It causes high mortality for herbivorous and ruminant species, but for carnivores and omnivores, they seem to be more resistant to infection and succumbing to disease. Next slide. So falling into the omnivorous species category, pigs have been documented to be relatively resistant to developing anthrax after exposure to the bacteria, and do in fact require higher infectious doses than do herbivores to develop and succumb to full-on disease. But since we do know that Bacillus anthracis is a soil-dwelling bacteria, and that pigs do have this propensity to root and wallow in the soil, we hypothesize that at least in contaminated environments that they may be a species that are most likely exposed to this bacteria just through their inherent behavior and relationship with the soil. Next slide. So given this information, we then asked, could swine exposed to Bacillus anthracis be used as indirect indicators of anthrax risk? So I have two maps up here. The one on the left is estimated feral swine distribution provided by the USDA across the US today. And then the map on the right is the current predicted environmental suitability for Bacillus anthracis. Importantly to note, a lot of studies have kind of tried to predict where anthrax is occurring on the landscape to try to predict future outbreaks, just taking past outbreak data as well as environmental information based on past isolations that have been made on the ground, and have used things like ecological niche modeling to try to map out the most likely areas that anthrax might be occurring. But a lot of this is unfortunately unvalidated in the field right now. And so what we're kind of proposing is, at least in the areas where feral swine are present, might we be able to kind of start validating these predictive models. Next slide. So we attempted to start answering this question by looking to the field and documenting the exposure of feral swine to anthrax, specifically in Texas. The USDA actually regularly removes pigs off of the landscape as part of their invasive species and damage management control program there, and samples a subset of those individuals by taking blood samples from them for regular disease surveillance for other pathogens. And so we kind of used archived samples from USDA that are kind of out here regularly sampling these pigs and tried to evaluate anthrax exposure across Texas. And then secondarily, because the agency also collects different demographic information on all the pigs they sample, we also wanted to see if any differences in exposure existed by pig age class and sex. Next slide. So as I mentioned briefly, the samples we examined were from Texas. We actually consciously chose Texas for our sampling as opposed to any other region or state with feral pigs, because Texas is a state that has pretty well described patterns of anthrax occurrence in domestic and wild ruminant species. with the vast majority of those cases coming from what's known as the Anthrax Triangle region, which is highlighted in orange on the map below. Cases are alternatively very rarely described outside of this triangle region, despite being equally populated with domestic livestock, feral pigs, and wild ruminants. So we have this really interesting situation where we have documented cases of anthrax in one region and not in another, and kind of homogeneous populations of both ruminant species that are highly susceptible to anthrax, as well as feral pigs who are not. So for our purposes, we considered those 7 counties highlighted in orange as endemic for anthrax, and kind of randomly selected 7 counties outside of that region and considered them non-endemic for anthrax, and went back into the USDA archive and pulled half of our samples from each of those regions for a total of 478 serum samples to then test for anthrax exposure. Next slide. So in terms of our methods for how we did this, we used an in-house ELISA platform similar to the one diagrammed here on this slide to look for antibodies against anthrax bacteria, specifically the protective antigen that's produced by wild-type Bacillus anthracis. Protective antigen is the cell surface binding protein used by wild-type anthrax to enter into cells and then distribute anthrax toxin into those somatic cells, and what's currently recognized as the bulk target of the humoral immune response in most resistant species. And so that's why we chose that as our coding antigen for our plates. And then statistically, we use logistic regression and fixed effects models to evaluate each of our covariates of interest and how they might influence a pig's antibody status. Next slide. And so this is a table documenting the seroprevalence that we ended up finding from our ELISA. And what we ended up finding in terms of seroprevalence was somewhat surprising, since most case reports of anthrax seem to just come out of that anthrax triangle region that we considered endemic. And you can see that we actually found similar levels of exposure between most of the covariates that we were interested in. But looking at the values rather crudely, we see that pigs coming from that endemic triangle region do appear to exhibit higher apparent seroprevalence than those in the non-endemic region. And then we also have rather similar levels of exposure happening in males and females, but with females being more likely to be seropositive than males. Next slide. So this is another figure documenting the raw serology results by region, since that is what we were most interested in. And something I think that's interesting to see here that you don't quite get with the table that was on the previous slide is that while we do have similar numbers of pigs from each region being considered seropositive by our assay or above that red cutoff line, we did have quite a few individuals that also exhibited absorbance readings above that, even from the positive control of our assay up on the upper right corner of that figure there. And that these appear mostly to be from individuals residing in that endemic triangle region. So it's hard to say exactly what this could be from with the data that we have here, but we kind of hypothesize that this could potentially be because the load of bacteria in that contaminated region could just be higher than that from the non-endemic region, or alternatively from repeat exposure events that result in higher antibody titers. Next slide. And then regarding our statistical models, it appeared that most variables we considered were informative for predicting a pig's antibody status. And the final model that was selected based on AIC value included all of our covariates, as well as the coordinate location that was associated with each pig sample. Interestingly, though, when we examined each covariate individually and calculated the confidence interval and respective odds ratio for those covariates, only latitude was statistically significant. And area under the curve measures suggested an overall poor model predictive ability, indicating that there might be some unexplained variance in our model. Next slide. So to summarize, it does appear that feral swine throughout Texas, both within and outside of that anthrax triangle endemic region, have been exposed to anthrax causing bacteria indicated by their positive antibody status. And despite similar seroprevalence, both within and outside of that anthrax triangle region, pigs within that endemic region did appear to exhibit higher odds of being seropositive than those outside. And additionally, female pigs also appeared to exhibit higher odds than males. And finally, despite our statistical model being unable to distinguish between endemic and non-endemic regions because of that unexplained variance that we observed, it's important to remember that these regions of endemicity, especially in Texas, are largely anthropogenically defined. And since we all know that animals and microorganisms don't often adhere to these nicely defined political boundaries, it's not completely unsurprising that we might find exposure occurrence outside of them. Also, given the fact that Bacillus anthracis is known to reside in a variety of environments and have been isolated in areas outside of that anthrax triangle region before, it's not unsurprising again that we might see exposure occurring outside of that. And in fact, that map that we showed in the beginning with those predictive models did predict some environmental suitability outside of that region as well. Next slide. So really quickly before we end our presentation here, I did want to kind of give a bit of a sneak peek as far as next steps in terms of anthrax research in relation to feral swine. This past year, we actually just wrapped up an experimental infection study looking to validate some of this field serology, where we took a group of naive wild-caught feral pigs and exposed them to various levels of the vaccine strain of Bacillus anthracis. And we did see that they had a measured immune response after we collected blood from them at several different time points post-infection. And looking at the graph on the bottom, you can see that that humoral immune response seems to correlate with both the dosage that those pigs were exposed to, as well as the number of exposure events that they experienced. Next slide. So this project would not have been possible without everyone in the Bowen Bosco Louth lab. I want to thank Dr. Richard Bowen and Dr. Angela Bosco Louth for letting me be part of this project. And of course, all of our collaborators at USDA for providing our samples and the data, as well as helping with our statistical analyses. And thank you all for listening. Next slide. That's done.
Thank you. Next slide, please. Our final presentation, the newly approved tick-borne encephalitis vaccine, who should be vaccinated, is by Susan Hills. Please begin when you're ready.
Thank you very much. So I am a medical epidemiologist in the arboviral diseases branch at CDC. And I have also been leading the ACIP TBE vaccine work group for the last 18 months or so as we developed recommendations for use of the vaccine. And so I'm excited to present that to you today. This is very new information. The recommendations were approved by ACIP just last week. So I'm pleased to be able to share this information. Next slide. So today I'm going to briefly review Tbe epidemiology, provide some information about the recently approved Tbe vaccine, and then discuss Tbe vaccine recommendations. Next slide. And I'll begin with providing just some basic information on Tbe epidemiology. Next slide. So TBE virus is a flavivirus, and it's related to Powassan virus, which of course is a tick-borne flavivirus found in the United States. There are three main subtypes of TBE virus, including European, Siberian, and Far Eastern subtypes. And TBE is focally endemic in a geographic region that extends from the western and northern parts of Europe right through to the northern and eastern parts of Asia that you can see there on the map on the right. Next slide. TBE virus is primarily transmitted to humans through the bite of infected Ixodes species ticks, and that's mainly Ixodes ricinus and Ixodes persiccatus. Transmission can occur occasionally through other means, and that includes ingestion of unpasteurized dairy products through infected goats, sheep, or cattle. And then rarely through some other means, including slaughtering of viremic animals, blood transfusion and organ transplantation have been documented as modes of transmission, breastfeeding, and also through exposure to the virus in the laboratory. Next slide. So infections are usually acquired in wooded or surrounding areas, and there's certain recreational activities or also occupations that can really result in an increased risk for exposure to infected ticks. Some of the key recreational activities that increase the likelihood of exposure include hiking, camping, fishing, and bird watching. And then occupational risk occurs for persons like forestry workers, farmers, military personnel, or also people doing field work, for example, for research purposes and exposed in that setting. Humans must enter tick habitats and come in contact with ticks to have a risk of TBE. And this is important to keep in mind because this is different from other arboviruses that are spread by mosquitoes, where the mosquitoes will actually search out humans. Ticks won't actively search out humans. So that's we've been keeping that in mind as we think about risk for exposure to TBE virus. Next slide. Because ticks are most active in the warmer months, the main risk period for infection occurs from April through November. With the majority of infections in those summer months, July, August, and the months on either side, June and September. Next slide. Clinical presentations of TBE can range from something like just a non-specific febrile illness through to neurologic presentations, including meningitis, encephalitis, or meningoencephalomyelitis. The illness can have a monophasic or a biphasic course. With the biphasic illness, the clinical course consists of typically a first phase of a non-specific febrile illness. This is followed by remission of symptoms. That's normally for 4 to 7 days. And then the second more severe phase occurs, and that's when the neurological illness occurs. The case fatality and sequelae rates vary by TBE virus subtype, but case fatality rates ranging from 1 to 20% and sequelae rates ranging from 10 up to about 50% have been reported from different areas. In terms of risk for poorer outcome, it's consistently been shown that older persons are at higher risk for a poorer outcome, and that's sort of incrementally higher as age increases. Next slide. In endemic areas, there are about 5,000 to 10,000 cases of TBE that are reported annually. Although there may be both underdiagnosis and under-reporting of cases from endemic areas. Next slide. Among US persons traveling to endemic areas, there have actually been a very low number of TBE cases diagnosed. So only 20 cases have been diagnosed during the last 20 years, and they include 11 cases in US civilian travelers, and 9 cases among military personnel. There again might have been some underdiagnosis. But really based on these cases that we're aware of, there's been a median of only 1 case per year. Next slide. So to just briefly describe one fairly typical US traveler case, this was an adult male in 2012, and he traveled to Finland to visit relatives. Next slide. Soon after arrival, he went on a camping trip, and he reported receiving multiple tick and mosquito bites. Next slide. Shortly afterwards, he developed fevers and myalgia. And those symptoms then subsequently resolved. Next slide. He then returned to the US, and about a week later, he again became sick and became very sick this time. He developed symptoms of dizziness, confusion, headache, and photophobia. And he was ultimately diagnosed with tick-borne encephalitis with the biphasic presentation. He was hospitalized for some time, but fortunately he recovered. Next slide. So that's US cases among travelers. And just to conclude, among looking at cases of TBE among other US persons and among other risk groups, I just want to talk a little bit about TBE among laboratory workers. So in laboratories, TBE virus transmission has occurred through virus aerosolization, and that has occurred either during laboratory procedures or handling of infected animal waste. And transmission through accidental percutaneous or mucosa exposures is also possible. There have been more than 46 laboratory-acquired TBE virus infections reported globally. These were mainly prior to 1995, with only a few reported since. And among those, at least 4 occurred among US laboratory workers. All of them, however, were before 1979, so none reported for several decades. Currently, there are fewer than 10 laboratories in the United States that work with TBE virus for diagnostic or research purposes. Although it's unclear, there is interest in use of work with TBE virus, and there may be an increase in work with TBE virus now that there is a vaccine available in the United States. Next slide. In regards to TBE diagnostic testing, there is no commercial assay available in the United States for diagnosis of TBE, but testing is available at the CDC. Next slide. So to move on to the TBE vaccine, next slide. So FDA approved the TBE vaccine, which is called Ticovac, and it's manufactured by Pfizer. Last August 2021, and it was approved for individuals aged 1 year or older. Next slide. It's an inactivated vaccine, and there are 2 dosing formulations, and that includes a 0.5 ml adult dose for persons who are 16 years and older, and then a 0.25 ml dose for children and adolescents aged 1 to 15 years. Next slide. This slide shows the vaccination schedule. So the primary vaccination schedule includes 3 doses, and that's shown in yellow. And 1 booster dose may be given, and that's shown in the green color. The schedule for adults is there in the top row, and for children, it's in the row below. For adults, the first 2 doses are administered 14 days to 3 months apart. And the only difference for children is that the first 2 doses are 1 month to 3 months apart. For both adults and children, the 3rd dose of the primary series is given 5 to 12 months later. Then a booster dose can be given at least 3 years after the primary series if ongoing exposure or re-exposure to TBE virus is expected. Next slide. The TBE vaccine is newly licensed in the United States, as I said, but it's actually been available for more than 20 years internationally, and more than 75 million doses have been administered. It's marketed in about 30 countries currently. These are countries primarily in Europe. And I don't have time during today's call to present all the safety and immunogenicity data, but it does have a very good safety and immunogenicity profile. Next slide. So just to summarize all that information, so TBE is a focally endemic disease that's found in parts of Europe and Asia. The virus is primarily transmitted to people through tick bites as they visit or work in forests or in the area on the edges of forests in endemic regions. Clinical disease can be severe with potentially high morbidity and mortality rates. Based on data from the last 20 years, cases among US travelers are very rare. Similarly, cases among laboratory workers are rare, but they clearly are at risk of infection when working with TBE virus. And a TBE vaccine has never previously been licensed in the US, but one vaccine has recently been approved and so is now available. Next slide. So based on that summary and to sort of conclude here with recommendations, I'm going to talk about the recommendations for TBE vaccination that were approved by the Advisory Committee on Immunization Practices last week. As I said, they're hot off the press and they actually won't be final until the CDC director approves them. So they're still pending final approval. But they have received ACIP approval last week, as I said. They were developed by a work group that we met about 30 times over 18 months to discuss epidemiology, to discuss the vaccine data, vaccine immunogenicity and safety, and then draft the vaccine recommendations. So quite a lot of discussion and work went into preparing these recommendations. So next slide. The work group's discussion on the risk-benefit assessment for use of the vaccine among travellers ultimately focused on several key factors, and they were that, as I've mentioned, the risk for TBE for most US travellers to TBE endemic areas is very low. Nonetheless, the disease has potentially high morbidity or mortality with older persons at higher risk of severe outcomes. And that there is a safe and effective vaccine, but that there is a possibility, albeit a very low probability, of severe adverse events. And that's just like all vaccines. The next slide. So the final recommendations for persons who travel abroad were that TBE vaccine is recommended for persons who are moving or traveling to a TBE endemic area and will have extensive exposure to ticks based on their planned outdoor activities and itinerary. In addition, TBE vaccine may be considered for persons traveling or moving to a TBE endemic area who might engage in outdoor activities in areas ticks are likely to be found. The decision to vaccinate should be based on an assessment of their planned activities and itinerary, risk factors for a poorer medical outcome, and personal perception and tolerance of risk. Next slide. And then considerations for vaccine use for laboratory workers included that there is a clear risk for disease for workers handling TBE virus, that the disease has potentially high morbidity and mortality, and that there is a safe and effective vaccine, albeit with a very rare likelihood of serious adverse events, as I said, like all vaccines. Next slide. Thank you. So the recommendation for laboratory workers were that TBE vaccination is recommended for laboratory workers with a potential for exposure to TBE virus. Next slide. So after the CDC director approves the recommendations, they will be posted on the CDC website, and the website will be updated with additional vaccination resources to help healthcare providers who are considering use of this vaccine. And an MMWR will also be published, which will have detailed disease and vaccine information. Next slide. And finally, I wanted to acknowledge the members of the ACI TBE vaccine work group. As I said, we worked over a period of 18 months to develop the recommendations, and each of these participants really put a lot of time and effort into that. So thank you very much. Thank you very much for your attention.
Thank you. Next slide, please. Thanks to all of today's speakers for your informative presentations. Links to resources from each presentation are available on our website at cdc.gov/onehealth/2022/march.html. We do have time for a few questions. Please use the Q&A feature in Zoom to send your questions and include the presenter's name or topic. We'll start off with a question for Amber. To your knowledge, have there been any studies of public perceptions or knowledge of rabies virus in the US or in other countries?
Yep. I'm more aware of there being different CAP studies in other countries looking at people's awareness of rabies and rabies vaccines. And I think, the barriers that we see are primarily related to both awareness and access. If we look at human rabies deaths in the US, we generally see similar features to the two cases from this fall who did not get PEP because they didn't realize their risk. So I think a lack of awareness is a major problem in the US as well.
Thank you. Our next question is for Rachel. Is there any evidence for serologic cross-reactivity in your assay with non-Anthracis Bacillus species or other bacteria? And then also, have you considered testing feral swine outside of anthrax endemic regions to test if the assay may be reacting with something else?
Sure. Yeah, that's a good question. So as far as I'm aware, and at least this is pretty well documented in the literature, that protective antigen that we were using for our assay as an antigen to coat our plates is a very specific antigen for Bacillus anthracis or generally anthrax-causing bacteria. I do know that there are members of the B. cereus family and Biovar anthracis that do also produce that protective antigen. But importantly, they've been demonstrated to also cause anthrax-like disease. So I think for our purposes, a measure of protective antigen antibody is pretty indicative of exposure to anthrax-causing bacteria. As far as cross-reactivity, while we were kind of getting our assay up and running, so I mentioned that USDA kind of regularly collects serum samples from feral swine throughout the United States. I actually did test a number of samples, a couple hundred, I think, from Guam to kind of confirm that there was no cross-reactivity because Guam, at least as far as public reports go, has not experienced any documents of anthrax in that region. So I did test Guam feral swine samples from USDA, and all of those were negative for protective antigen antibody.
Thank you. And then we have one question for Susan. You mentioned that TB virus is related to Powassan virus. Do you know if the TB vaccine could potentially be effective for Powassan virus?
Yeah, thank you for that question. There is limited data investigating that question, but the data that are available do not suggest that the TBE vaccine will protect against Powassan virus infection.
Thank you. And then we have time for one last question. This one is for Rachel. Given the results of your study on feral swine, do you think that there is a risk of anthrax transmission from feral swine to humans in regions of the US, for instance, among hunters or those who may have recreational or occupational exposure to swine?
Yeah, I think definitely in some cases there could be a documented risk of exposure specifically to feral pigs. Now, I'm not sure what kind of exposure that would take, just because feral pigs are a relatively resistant species to developing disease. So I think it would probably have to take a pretty high exposure dose for them to successfully become infected and then be able to pass it on through their carcass or something like that. Now I will say that we are also interested in seeing if you might be able to isolate spores that feral swine could potentially be carrying either on their fur or in their nasal passages after kind of rooting around in that soil and contaminated soil. And so hopefully more to come with that, but I think that that could potentially be a risk for sure.
Thank you. And that is all the time we have for questions today. If you have other questions for today's presenters, we've included their email addresses on this slide on the ZOHU Call webpage for today's webinar and in today's email newsletter. A video of today's webinar will be posted within 30 days as well. Next slide. Please join us for the next ZOHU Call on April 6th. Thank you for your participation. This ends today's webinar.